The BMI podcast is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. Be sure to check out our description below for our website and social media platforms. I'm your host, Dr. Drew Crawford. I'm a board-certified gastroenterologist and obesity medicine specialist. Thank you for joining me today on the Beyond Measurements and Image podcast. Today we're going to discuss the GLP-1 drugs. They seem to be the wonder drug, and they do have a lot of benefit. So we're going to discuss how they work, what the benefits are, what the potential adverse effects are, some reasons that you absolutely don't want to take them in certain populations, and what the long-term effects of them are in terms of weight loss. So with that, let's start by just getting a little in the weeds in terms of what GLP-1s are. GLP-1s are glucagon-like peptide-1, right? It's a specific little molecule that's released by what's called the L cells in the small bowel, particularly in the lower part of the small bowel called the terminal ileum. There's another one similar to it called gastric inhibitory peptide, or GIP, and it's released from the K cells in a different part of the small bowel. Now, you don't have to remember any of this, but just recognize that these are small little proteins that are released from the gut, and they have significant effects on how we metabolize sugar and how we have the sense of being full or being hungry. The GLP-1 is a class of drugs. So there's actually a glucagon-like peptide 1 that's released by the L cells. So when I talk about GLPs, I'm actually talking about the drug, the GLP-1 analogs. They're the ones that are created in the lab that are then used as a medication. So there are some differences, but let's start by just talking about the GLP-1s, right? So they're naturally occurring. They come from the small bowel, very specific cells. The actual half-life of the native GLP-1, the one that our body makes, is about 2 minutes. So the pharmaceutical companies have made some alterations to the GLP-1 molecule. Now it can last anywhere from about 12 hours to about a week, or about 184 hours. So how do they work? So the GLP-1s, whether it's synthetic or naturally occurring, they behave in the same manner. These molecules, they're released from the gut, or they're injected into the subcutaneous tissue if it's the drug form. And they do a few things. One of the things they do is they stimulate the pancreas to release insulin. So remember, insulin comes from the beta cells of the pancreas. And when we eat and our blood sugar goes up, insulin is secreted from our pancreas, and it helps to bring that blood sugar down and kind of drive that sugar into where it needs to be. Now, in patients with type 2 diabetes, this doesn't really work very well. They do continue to make insulin, but they don't make it very well. And in patients with type 1 diabetes, they don't make insulin at all. So they have to take exogenous insulin, or they have to take insulin in the form of a shot for the rest of their life. The GLP-1s, one of the things they do is they stimulate the beta cells of the pancreas to release insulin. And that insulin helps to drive down the blood sugar. Now, they also stimulate the alpha cells of the pancreas. So the alpha cells of the pancreas secrete a molecule called glucagon. And that then causes a whole host of effects. But one of the things that it does is it causes the glucose that's stored in the liver, it's stored as glycogen, to then be broken down, and it elevates the blood sugar. So by inhibiting glucagon, you inhibit this breakdown of sugar in the liver. And so you don't raise the blood sugar there, and you're stimulating the insulin production, so that helps to bring the blood sugar down. So you can see how these medications are used in patients with type 2 diabetes. And they're not really used in patients with type 1 diabetes, because remember, patients with type 1 diabetes don't make enough insulin on their own. So even with the stimulation of this, it's not really effective in patients with type 1 diabetes. But in addition to the effect that these drugs have on the alpha cells and the beta cells, these drugs also slow the gut down. That has a couple of effects. So when we eat, like we chew our food and we swallow it and it sits in our stomach, and then our stomach kind of grinds it up a little bit, and turns it into like a paste, which then is pushed into our small bowel in almost a liquid form. And then our small bowel has all these little villi, all these little finger-like projections. They're microscopic, but there are billions of them. And that creates all this surface area, and that liquid is then absorbed and the nutrients are absorbed. So if you slow the rate of emptying from the stomach into the small bowel, you don't have this big bolus of food going into the small bowel that then gets absorbed and causes the blood sugar to rise all of a sudden. It's a much slower process. It slows that down. So what happens is, although your blood sugar comes up a little bit, it comes up in a more controlled manner, in a slower, and you don't have these big spikes that you would have if you just had normal gastric emptying. So the GLP-1s slow the gastric emptying so you don't get this big surge of food into the small bowel to be absorbed, which would then spike your blood sugar. So by slowing that down, it helps keep your blood sugar lower. And then remember, it also stimulates the beta cells of the pancreas to secrete insulin. And when it does that, that helps to bring your blood sugar down. It also has the added effect of stimulating the alpha cells of the pancreas, which then inhibits the breakdown of sugar from the liver and from the muscle. So all of these processes are very helpful in managing diabetes. So in addition to the management of diabetes, let's talk about how this works in obesity or overweight. So if you're able to control the rate at which your blood sugar rises and drops, that also helps with satiety. One of the things that causes us to be hungry is that we eat and we get this sudden rise in blood sugar. And then when it crashes, that sends a signal to our brain that we need to eat. And so that causes us to be hungry and go back and eat more. Right? So these big spikes and dips in blood sugar cause some issues with hunger and eating. So if you can sort of level that out where you don't have those big crashes, that can help to some extent with managing not only your blood sugar, but also your hunger and your cravings. The other thing it does is by slowing the gut down, you have a sense of being full sooner. And if you're full sooner, then you don't necessarily want to continue to eat, right? Think about Thanksgiving dinner, or just think about a big meal, right? You eat till you're full and then you stop. So if you slow the gut down and you get full sooner, you stop eating sooner, and in turn, that decreases your caloric intake. Now, GLP-1s also have the added benefit of they bind a receptor in the hypothalamus of the brain that leads to a sensation of satiety or a sensation of fullness, and this decreases hunger as well. So these medications work miraculously not only to control diabetes, but they also work quite well in managing hunger as well as a sense of feeling full. So additionally, what else do these GLP-1s do? Well, they've been shown to lower blood pressure, they lower total cholesterol, they appear to increase heart function and coronary artery blood flow, they increase cardiac output, they've been shown to decrease overall risk for cardiovascular events and lower all-cause mortality. They're also shown to decrease the hemoglobin A1C, which of course we would expect because we're managing our blood sugar levels better. So they seem like a miracle drug, right? They cause weight loss, they improve cardiovascular function, they manage your diabetes, right? We've talked about the benefits of losing just 5% of your body weight and all the benefits that you get from that. And you get a lot of that just from these medications alone. That's the upside to the medications. The downside to the medications is that it can cause issues with nausea, vomiting, diarrhea, constipation. In severe cases, if you have a lot of nausea and vomiting and diarrhea, you can get dehydrated and cause some acute kidney injuries. These are injected subcutaneously. There are oral forms that we'll talk a little bit about. As a general rule, you inject these into your subcutaneous fat, and you can get some site irritation where that gets injected. They're also known to cause some biliary disorders, particularly gallstones, and in some patients, they cause pancreatitis. Let's talk about the nausea. That seems to be the biggest component. So why does it cause nausea? Well, remember, one of the things that it does is it decreases gastric emptying, right? It slows the rate of gastric emptying. That's beneficial in the sense that it does cause you to feel full sooner, but it also can make you feel nauseated, right? If you're not feeling well, if you're sick, just say you have a viral gastroenteritis or something, a lot of times it just slows the gut, right? And so what you ate 12 hours ago, you get sick and you throw up. It's because your stomach just isn't emptying quite right. Obviously, that's not the natural course of things, but in patients who are on these medications, by design, these medications slow down the gut, right? The GLP-1 component slows that gastric emptying down, which can be advantageous in terms of making you feel full, but in some patients, it causes you to be nauseated. Now, remember, these medications are used initially for diabetes. So one of the complications of long-term diabetes is what we call diabetic gastroparesis. And that is where you just have poor gastric emptying as a function of the diabetes, right? Usually occurs in patients that have had diabetes for a long time, and then they glycosylate those nerves and you're just not able to empty the stomach. And so it can be a very incapacitating problem that these patients have. And obviously, if you have a patient that has diabetic gastroparesis, a GLP-1 is not a good choice of medication, either for weight loss nor for control of the diabetes. The vomiting, of course, is secondary to that same process, and as is the constipation, right? It just slows the gut down. It is interesting, though, the medication itself also can cause some issues with diarrhea, and so you have to guard against dehydration with this. So again, overall, medicine sounds fantastic, right? It does all these things. It causes weight loss. It helps to control diabetes. It protects the heart. It decreases all-cause mortality. You're thinking, gosh, I mean, what are the downsides? Well, we talked about them: some nausea, vomiting, diarrhea, constipation, irritation at the site. Some patients get increased gallstones, and some patients get pancreatitis. So pancreatitis, that can be a fatal disorder. That's when the pancreas gets markedly inflamed, and there's a whole host of things that can cause it, right? Gallstones actually can cause it in the right setting. Alcohol oftentimes causes it. Medications cause it, and one of the medications that cause it are these GLP-1s. In patients that have pancreatitis, either a history of pancreatitis or definitely pancreatitis induced by these medications then are contraindicated. Another absolute contraindication to GLP-1s is pregnancy. And in fact, if you have a patient of childbearing age, they should be on some form of birth control. Additionally, reasons to not use these are, like we talked about, patients who have gastroparesis from underlying diabetes, or really any reason for gastroparesis, although diabetic gastroparesis is by far the most common. Also, patients with inflammatory bowel disease such as Crohn's disease or ulcerative colitis would be well advised not to be on these. An additional contraindication, or an absolute reason not to use these in a certain population, is patients with medullary thyroid cancer, or what we call multiple endocrine neoplasia type 2A or type 2B. Right? And so what we know is Liraglutide, or Victoza, one of the original GLP-1 drugs, was shown in rodents to stimulate calcitonin release, which then in turn causes thyroid gland C-cell and tumor hyperplasia. Now, whether that has the same effect on humans, it's unknown, but medullary thyroid cancer obviously is not a risk we're taking. And so patients with a history of medullary thyroid cancer or multiple endocrine neoplasia type 2A or 2B should avoid this, and it is actually contraindicated. Not only that, but patients who have first-degree relatives, meaning mom, dad, brother, sister, or child, with medullary thyroid cancer or MEN should not be on these medications. And then lastly, patients that have severe renal dysfunction. These medications are cleared through the kidneys, and oftentimes diabetic patients tend to have renal problems, right? One of the complications of long-term diabetes is chronic kidney disease, and that's why you see so many patients on a dialysis unit that have diabetes, right? So if you have severe renal disease, you should not be on a GLP-1. So if you have mild to moderate renal disease, it's okay to be on these medications. You just want to discuss this with your doctor and make sure that it's being monitored relatively closely. Who should be monitored? Well, obviously, if you're diabetic, you should talk with your doctor about being monitored, right? Monitoring that hemoglobin A1C. You and your physician are likely monitoring that already just by virtue of the fact that you're diabetic. But with these medications, they do alter your diabetes profile, so you want to make sure that you're keeping that in check. Also, if you're on Coumadin or warfarin, you should follow your INR. Now, again, you and your physician likely are following this anyway, but when you have decreased gastric emptying, you can alter the rate of absorption of these medications, and they can be somewhat erratic, and it can cause alterations of this. So you and your physician should talk about closely monitoring that INR, which again, you likely are anyway, but with this, you might want to have some heightened monitoring. Also, patients that are on this may want to have their calcitonin checked, at least initially and maybe periodically, because we know that elevated calcitonin can be seen in patients with medullary thyroid cancer. If you see that begin to creep up, you and your physician would want to have a discussion about possibly coming off of this. Also, pancreatitis is not a subtle process. When you have pancreatitis, you have severe pain in the epigastric area. It tends to radiate through to the back, oftentimes requires hospitalization. And like I said, it can be fatal. So monitoring for pancreatitis isn't something that you necessarily need to discuss with your physician. But if you have any sort of abnormal abdominal pains like this should be a discussion that you have, because if you have an elevated amylase and lipase, or you have clinical signs of pancreatitis, it would want to be discontinued. Who else should be monitored? Well, if you're going to have surgery, a lot of times you want to be off these medications for at least a week. There's no clear guidelines from the surgeons, from the gastroenterologists, from the anesthesiologists as to what to do. In fact, just recently, this past week, another paper came out saying that maybe we don't need to hold them. But currently, our practice is that we hold these medications for 1 week before doing any sort of procedures. So as a gastroenterologist, we sedate patients. We have anesthesia. They sedate patients. And then we take a scope and we either do a colonoscopy, where we take the scope and pass it in through their bottom and look at their entire colon, looking for polyps and tumors, etc. Or we take a different scope and we go down in through their mouth, look at their esophagus, their stomach, the first part of their small bowel. Now, when we do that, oftentimes they're sedated either with what we call conscious sedation, such as like fentanyl and Versed, or more commonly and almost exclusively, we use a medicine called propofol. So the patient's completely asleep, so they maintain their own bodily functions, including breathing on their own. So it does not necessitate that the anesthesiologist put a tube in their throat to breathe for them. So if they did that, they'd put a tube in their throat and they'd inflate a balloon in there. So that way, if they threw up, right, it wouldn't go down into the lungs. But when we do what we call monitored anesthesia care, right, the patient breathes on their own. They don't require that a tube be put into their trachea to breathe for them. So if they were to throw up during the procedure, that airway is not as protected, and some of that gastric content could get into the lung and cause a pneumonia or hypoxia, or it could, under very rare circumstances, even be fatal. So what we've adopted is a process where we have them stop these medications for 1 week before. So it's essentially, if it's Semaglutide, that's just one dose. We have them stop a week before, and then we perform the procedure. Now, it's not entirely clear that stopping it a week before returns the gastric emptying function back to normal, but we don't have any clear guidance. And so that's what our groups come up with. And nationwide, that seems to be a trend, although the studies are still pending as to what to do with that. So currently there's basically 2 GLP-1s that are used. One is Liraglutide or Victoza, and the other is Semaglutide or Ozempic. Now, the difference is the Liraglutide has a half-life of about 12 hours, and the Ozempic or the Semaglutide has a half-life of about 184 hours. So that's why it's dosed that way. Liraglutide is dosed every 12 hours with a subcutaneous injection, and Semaglutide is dosed once a week. Sometimes Liraglutide is dosed once daily. When you look at the studies, it does not look like Liraglutide has the same effect on weight loss that Semaglutide does. And it's thought that likely, with the half-life being 12 hours, you give yourself a shot and you have all those benefits where the GLP-1 component goes in and stimulates the beta cells to secrete insulin and inhibits the alpha cells from secreting glucagon. And it binds that receptor in the hypothalamus to decrease satiety, and it slows the gut down. But after 12 hours, that medication is then degraded, and then you're back to normal. And so then the inhibition of hunger that happens in your brain and the slowing of the gut, it all returns to normal. So you have these sort of ebbs and flows, or at least it's postulated that there are these ebbs and flows to the use of that medication, as opposed to a long half-life medication that lasts about a week. So you give yourself the injection, and over time, it just slowly releases from the subcutaneous tissue, the sort of a perpetual and more of a sustained stimulation of the hypothalamus to decrease your appetite and to slow that gut down and to keep those insulin levels appropriate to the blood sugar level. So let's just talk a little bit about the Liraglutide, right? So a series of articles have been published regarding GLP-1s. So I'm just going to cite a few of them. One of them where they looked at healthy weight loss maintenance with exercise, Liraglutide, or both. And what they found was that when they randomized patients into the different arms, the patients who were on both Liraglutide and exercise did better than the patients who were on exercise alone or Liraglutide alone. And of both of those alone did better than the patients on placebo. So clearly, exercise did better than placebo alone. Liraglutide did better than placebo alone, but the combination of exercise and Liraglutide did the best in that study. Now, when they looked at the effect of weekly subcutaneous Semaglutide or Ozempic versus daily Liraglutide, what they found was that there was significantly better weight loss in patients on the Semaglutide. Patients on Semaglutide lost about 15.8% of their weight versus only 6.4% body weight loss in patients on Liraglutide. Now, when you compare that to the placebo arm of that study, they only lost about 1.9%. So Liraglutide did better than placebo, but Semaglutide did significantly better than both. In that same study, the side effect profile was essentially the same, right? The weight loss was different, which was the primary endpoint, and really the one that you're most concerned with. But the complications of nausea, constipation, diarrhea, vomiting, headache were all essentially the same. The side effect profile of the patients taking the medications tended to be worse than the placebo, which would be expected. Another interesting statistic is that it does appear that the reduction in caloric intake versus placebo appeared to be larger with Semaglutide, with an approximate 35% reduction in caloric intake, as opposed to an approximately 16% reduction in caloric intake of Liraglutide, which would be about consistent with the body weight changes. So in that study, obviously, both of the medications were effective at weight loss. One was a little bit more effective. The side effect profiles were about the same. Now, another study in that same series, what we call the STEP randomized clinical trials, there was an additional study showing the effect of continued weekly subcutaneous semaglutide versus placebo on weight loss maintenance. Now, this is interesting. So the initial study looked at just the overall weight loss, right? And so in this study, what they did was they took patients and they got them up to the weight loss dose of 2.4 milligrams over 20 weeks. So with the side effect profile, right, the nausea, vomiting, diarrhea, constipation, if you just take a patient from no medication and put them on 2.4, it'd be very difficult to handle. So they start them at a low dose and they escalate them over the course of 20 weeks. And then after 20 weeks, they either randomized those patients into a placebo arm where they weren't getting any of the medication, or they were continuing on the 2.4 milligrams of semaglutide. And what they found was the patients who continued the semaglutide, not surprisingly, not only sustained their weight loss, but continued to lose weight, where the patients that were switched to placebo then gained most of their weight back. Also, within that, they looked at waist circumference. So the semaglutide patients continued to lose waist circumference, whereas the placebo patients gained it back as well. Also, the benefits that were seen in systolic blood pressure, body weight, BMI, hemoglobin A1C, fasting plasma glucose, fasting insulin levels, as well as fasting lipid profiles, all of the patients who continued on the semaglutide continued to decrease, and all of the patients that were switched to placebo continued to return. Now, they didn't all return back to their original baseline, but they all went back up. To be specific, the estimated mean body weight change from week 0 to week 68 was 17.4%. So the first 20 weeks, they were all brought up to the 2.4 milligrams. And then at that point, they were switched either to continue on semaglutide or placebo. Of course, the patients and the people doing the study did not know which one they were in. And what they found was the patients that continued on the semaglutide ultimately ended up with an approximate 17.4% weight loss. And the patients who then went on placebo had an only 5% weight loss. So from these studies, what we've seen is that the medications, the GLP-1s, both of them are available. Liraglutide and semaglutide are both effective, right? It appears that the semaglutide may be more effective at weight loss. And then the longer term, up to 68 weeks, tends to be more effective, right? When the patients come off of it, they tend to revert back toward their original weight. Now, that number does seem to plateau around week 60 to 68 in terms of weight loss. So yet another study looked at weight regain and cardiometabolic effect after withdrawal of semaglutide. So that original step 1 trial that I talked about, where they studied patients over 68 weeks, they extended the follow-up on a group of those over the following 52 weeks. And essentially what they found was that there was a substantial reduction in weight over those first 68 weeks, but once that medication was withdrawn, it led to most of the weight loss being regained within 1 year and a similar change in some of the cardiometabolic variables back to baseline. So this then implies that this medication needs to be a long-term treatment. So semaglutide and liraglutide are effective, right? And then there's the combination drugs like Mounjaro that have both the GLP-1 as well as the GIP that we initially spoke about. GLP-1s, they're effective, but what we see is that it may be one of those things that you'd have to be on lifelong. It does appear that the weight loss benefit plateaus around week 60 to 68. But that's a lot of time, right? Week 60 to 68. What I would suggest is that if you're unable to lose the weight by just making the behavioral modifications that we've talked about in the first few episodes, tracking your calories, tracking your energy expenditure, working to decrease it, setting a goal, right? The SMART goals, determining your why and having that emotional connection, right? If you need more than that, these GLP-1s are a good addition. But I don't know that you want to commit to a medication that you're going to have to be on lifelong, particularly if there's no sustained benefit after 68 weeks. What I would suggest is if you're going on one of these medications, you need to think about it in terms of this, right? It's a good way to kind of jumpstart things. It's a good way to get your mind working in the way of losing weight. But what you need to do is over those first 20 weeks, 60 weeks, 68 weeks, whatever it is, over that period of time, you need to start adapting and making those lifestyle changes so that they can become permanent, so that when you come off the medication, You've had all that time to really begin to work on your exercise and make sure that you're doing at least 2 days a week of strength training so you can maintain your lean muscle mass. And then also work on your dietary modifications, decreasing the calories and making the healthy choices. These are a great way to get started, but I don't think this is the long-term answer. I don't think a lifelong medication necessarily needs to be the answer, but boy, how great is it that we have an option that can maybe get things jump-started for us, and then we can kind of work on our behavioral and psychiatric issues that need to go with it, and whatever else that we need to kind of work into and feed into our lifestyle changes. Because remember, these changes have to be lifelong. It can't just be temporary. And then once you lose the weight, you go back to the bad habits you have. You have to have a complete alteration. One of the things is we know from the previous podcast is macronutrients don't really matter, right? If you go on a high-fat diet, a low-fat diet, a high-carb diet, or a low-carb diet, at 2 years, there's no sustained difference. But what we do know is that a high-protein diet does help preserve lean muscle mass, as does working out with strength training at least twice a week, or resistance training at least twice a week. So over that 68 weeks, you can begin to kind of build these things in. When you're on these medications, you do lose total body weight, but right, you also lose lean muscle mass. So you have to guard against that and you have to work for it. What's the take-home message? Well, let's continue with our goals. Let's determine our why. Let's pick our goals. Let's make the changes that we need to make and start working toward those goals. If we need the assistance of some drugs to help with this, these are a great choice, and you should talk with your physician about it. I would just suggest that you really think long and hard about not making this a lifelong commitment, but rather making this something that is a bridge to a healthier lifestyle. It'll help you get there, and it'll give you time to start making those changes and start embedding them into your daily life and your daily routine. So I know that's a lot. I hope this answers a lot of the questions that you have about GLP-1s and gives you a broad overview. So if you have questions, don't hesitate to go to our website. I will do my best to get to them and help you on your journey. I'm your host, Dr. Drew Crawford. Join me next week as we go beyond measurements and image to build a healthier lifestyle and elevate your well-being on the BMI podcast. See you then.